This is a talk about the sort of next generation of what we're trying to do with robotics, and so I've entitled it The State of the Art of Urologic Robotic Surgery. So urology was actually one of the first specialties to embrace robotics. The first prostatectomy was done, where we removed the prostate, was done in 2000 by Dr. Menon in Detroit. Initially, the robot was thought to be used for cardiac surgery, and the ergonomics weren't good for it. So urology really embraced it for pelvic surgery with the first 3-arm robot, and that robot has become much more robust as it has evolved. And the good thing about this is that it allows all of these specialties to now use a more robust instrument. Prostate cancer is one of the most common cancers for men. It is the most common cancer after skin cancer. 12% of men are diagnosed with prostate cancer in their life. And prostate surgery done robotically is done in 95% of prostate surgery for cancer. Kidney cancer is the 6th most common cancer in men, 8th in women, and it affects about 2%. And in cases where we can save the kidney, it's estimated that about 75 to 80% of these are now done robotically. And the nice thing about this is that we're able to save kidneys, and this has replaced many of the traditional open surgeries where we have a big incision and the total kidney removals, total nephrectomies. So we're going to review some of the advantages and the abilities of the robot that has facilitated this sea change for us. There's benefits to all parties involved here. The surgeon has many benefits, and one of the things is that this robot helps us democratize or make it easier for us to do these technically difficult operations like kidney sparing. The kidney gets a lot of blood flow and is behind everybody else's organs, so we have to move some of the other organs to get back there. And by having this magnification and being able to visualize the anatomy much more precisely, we are able to do these kidney sparing operations, which is better for us. And ultimately, that helps us with the patients. Patients have much smaller incisions. You saw with Dr. Schubach's talk, there's a large flank incision up high. For the kidney, it's down lower. And this way, we're able to do it with 4 or 5 smaller incisions. The blood loss is much less. The complications are down significantly. Length of stay, most of these patients go home the next day, sometimes even the same day. Pain scores have been shown to be significantly less. And the great thing about it is that we're able to preserve a lot of the volume of the kidney. Here we can see just, this is historical, 2015 and 2008. This red line is the only thing you need to take a look at. This red line is the robotic partial nephrectomies. And so what we see here is that the blue line, where we had the radical nephrectomies, meaning the total removal of the kidney, is down significantly to the point where we've now replaced total kidney removal with partial kidney removal. And a lot of that is attributed to our ability to do these more precise surgeries robotically. So what are the advanced technologies that allow us to do this? We're able to achieve much closer margins, and what that allows us to do is save more kidney. There's lots of ways that we do that, mostly the magnification and the tool that the robot is, the ergonomics of it that we've seen already. And historically, before, I remember training, they would tell us, take a 2-centimeter margin. It's an inch wider than the tumor. The kidney's only 10 centimeters long or 5 inches long, so we're taking a big chunk. We've seen that the cancer control is the same even if we stay closer, and the recurrence rate is very, very, very low. And we have lots of ways of doing this. Yes, the robot, yes, the magnification. We have something called near-infrared fluorescence, which we'll see in the next slide, gives us a lot of advantages. So what we do here is, in these cases, and I'm not going to show you any videos, I don't want to scare anybody, and the other surgeons are much better than I am, so I'm not going to show you my highlight reel. But we can inject some green dye into the arteries, and you'll see that the kidney is going to light up. All of the organs are going to light up. We can selectively clamp in some cases, or clamp the entire kidney, just to make sure that the kidney is not getting blood flow during this part of the operation. We can see where the tumor is in this cartoon, and we can see that we've selectively clamped the correct artery. It's red after here, and we're only affecting a very small part of the kidney in this case. In other cases, we can see that giving this dye during the surgery helps us to differentiate the green normal kidney with the darker tumorous kidney. And this, again, allows us to achieve these negative margins. It's a flip of the switch robotically. We really don't even have to change anything. We do it in real time during the operation after the anesthesiologist has helped us. And you've heard from all the team here. We don't have any of the anesthesiologists here, but this is really a team approach. We're lucky to have all of the nurses, the PAs, the techs, and even the other specialists, right, who come in and bail us out if we ever need to, or give us a second opinion. So with kidney cancer, we also have other things that help us: 3D modeling on the CAT scans beforehand, and ultrasound during the surgery. And this allows us, again, to preserve more volume. Here, I'm not going to roll through this, but this is a tumor, and this is the kidney. There we go. Let's go back. And what we can see is that we can see normal kidney, and on the ultrasound, again, picture in picture. The surgeon is not lifting his head up. He's not leaving the console. He's not distracting from the surgery. He can control multiple instruments at the same time, or she. And what we can do is we can take a look inside the kidney and determine how deep this tumor is. We can take a look and see if it's closer to any of the arteries than it should be, or if there is any blood vessels or collecting system or anything that is going to affect our surgery or our ability to control the cancer, because ultimately these surgeries are done for cancer control, the vast majority of them. The good thing about the robot is that it's also allowed us to do reconstruction. So not just the cancer stuff, but helping people reattach things in a way that's going to help preserve their kidneys to avoid kidney failure, dialysis, and other issues. So we've had multiple surgeries where we've been able to do reconstructions, and this continues to evolve as surgeons come up with newer ideas, with newer tools. We've now been using appendix as a flap to help bridge a gap sometimes. We can use lining of the inside of the cheek as a flap, or as a free flap, and help as a patch if there's a gap again. Right? These are rare, but these are things that we're able to do. As you saw with that grape video, we can do very, very delicate surgery when we need to, and we can remove big organs when we need to through a much less invasive approach. We use robotics in pediatric surgery, and we can use that for reconstruction over there, where we put the kidney back together from an anatomical variation that's affected them. So that was the kidney stuff. Prostate. We're going to be quick on this as well. Prostate anatomy is challenging, right? When we see these cartoons and we see these videos online, everything looks like it's all separated out. For those of us in the operating room, we know that everything's fused together, right? There's no such thing as different colors or nerves that are bright yellow, and rarely do these things separate as easily as we show on some of the videos. The advantages of the robot is that we have much improved magnification. We have 7 to 10 times magnification improvement. We have much less bleeding during the surgery, especially down here in the pelvis, and that improved bleeding makes us see better. Nerve preservation, which is the big concern during prostate surgery. We are able to peel the layers away. It's like layers of an onion. These layers are fused together, and if you didn't know they were there, you would remove them by accident, and that would affect a patient's function afterwards. We have scaling of the movement. So when my hand moves this much on the outside, it moves this much on the inside. So we have much more precision, and I can actually change that scaling if I wanted to during the surgery. So I can make it more precise or be able to have broader movements if I was more comfortable that way. And we're even using this now in non-cancerous treatments for the prostate. We can remove a very large prostate and reconstruct it and make it look like we were never there, right? Again, for non-cancerous things. So the advantage of these, all of these surgeons working in different specialties, is that we're all kind of combined and putting things together. And that really is the art of medicine. And for those of you who knew him, Ken was a Renaissance man. He's a special person. He's still with us. He's still with us in the operating room all the time. And as a Renaissance man, he helped all of us broaden our focus and our specialty. And it's try not to get too emotional here, but we're all here for him. And a lot of what he has taught us has gone out and been disseminated to the rest of us. So I want to thank you all. Little quick talk. All right.